So this has been a little series that we've developed on medical errors, and what we do is look at our own error cases, analyze them, and try to learn from our own experience. And Hugh, can I turn to you to hear about your case?
Yeah. So my case is a pretty straightforward case. Again, I'm an electrophysiologist. I see a lot of patients with syncope and pre-syncope, and this is, I think this case illustrates something that I've learned over time that I wasn't aware of, years ago. So anyhow, it's a 25-year-old woman who has intermittent episodes of dizziness. She describes this sort of dizziness as a sense of imbalance. And I must say that I've always sort of focused on trying to separate out, are you dizzy? Do you feel like you're going to pass out? Or do you feel like you're spinning or have imbalance? And I always held it to be true that there's sort of very different symptoms that head in different directions. These occurred while standing and never had an episode of syncope. So her physical examination was really unremarkable, as was everything else, her echo and her event monitor and EKG. So we did a tilt table test, and she was very positive. Within 20 minutes, she had a typical vasodepressor response. And what I found surprising and I learned from is that this sense of lightheadedness was reproduced, but also this imbalance sensation. And I have to admit that for the first 15 years of my, or 20 years of my career, if I've been out of HMS for 30 years, so for the first 20 years, I always thought that if you had imbalance, it's not vasodepressor syncope or vasodepressor pre-syncope. It's, send them to the ENT folks. But this case taught me that in some patients, this imbalance sensation you can get with a vasodepressor syncope. And, I've discussed this with our neurologists here, and they said, yep, it's incredibly rare. But they came up with explanations, and maybe our experts can comment on that. Yes, this imbalance sensation, it is seen, although it's not typical of, vasodepressor syncope, where you have the usual loss of visual fields and your loss of hearing and, lightheadedness and so forth. So anyhow, we gave her the usual treatment of more salt and fluid, education. One thing that I do with lots of these patients with orthostatic intolerance syndrome is I tell them to put a couple of those books under the head of their bed, and her symptoms resolved, and she's doing well.
So let me ask you, Hugh, this whole thing about vasodepressor and neurocardiogenic syncope is somewhat cryptic, and it's filled with a lot of different sub-diagnoses. So here you have a young person who has this syndrome. What do you think the pathology is? Where is it? Is this a central nervous system disorder or a peripheral nervous system disorder?
Well, I mean, I at least from the electrophysiologist perspective, one, I like the term neurally mediated hypotension rather than vasovagal syncope or vasodepressor syncope, because many patients like this, have episodes of dizziness or lightheadedness but don't have frank syncope because they abort the episodes, they sit down and so forth. I mean, I've always, when I think about the mechanism, it's, occurs when sitting or standing, they pull blood in their legs and feet, less blood returns to their heart, their catechol go up, their heart beats more vigorously, they have this volume depleted empty ventricle that triggers the mechanoreceptors, and that triggers this reflex. And so that's, now why some people have it. Why is it a third of the population has this tendency to have vasodepressor or neurally mediated hypertension and 2/3 don't? I'm not quite sure. We obviously are very well aware of the fact that it tends to run in families, but whether the abnormality is peripheral or it's central or it's these mechanoreceptors, you're going to have to tell me the answer, Marty, because you always had all the answers in medical school, so don't let me down now.
Wish that were true. I have been prescribing this. I mentioned it before, and I'd be interested in your reaction or the others' reaction to this leg crossing, thigh clenching maneuver, and it has been shown in reasonably done studies to actually work, and I've certainly had good success with this. Have you tried that? You treated her with salt and fluids. Sometimes in the older folks, that doesn't work so well because of the cardiac complications. What is your experience with, and what's your view about the physical maneuver to just squeeze blood out of the thighs and get them into the central circulation?
Yeah, no, I'm impressed that the data on these maneuvers really sounds pretty good, although it makes me nervous, if someone's having pre-syncope and you say, okay, cross your legs real hard, and you sort of give them the sense that's going to protect them, as opposed to, get down. I hate to think if the maneuver doesn't work and they end up passing out and falling the wrong way. So I think the message I try to give patients is, if you feel it coming on, sit down, lie down, whatever. I think the other really interesting thing is this sort of mind, the mind games this condition plays with patients, and this issue about placebo effect being important in the treatment. As we all know, this tends to come in bursts and can be unbelievably debilitating for a patient, where you go into a certain situation. I've had patients who are surgeons and physicians that need to be on their feet, and it's a really debilitating problem. But I think part of the treatment is telling them what it is, giving them a treatment, and prescribing the placebo with confidence that you do this will take care of the problem. And I think that plays a long way to treating the patient, and exactly what it is about this sort of mind-body. They come in spurts, and if you're thinking about it a lot, and you think you're going to pass out, well, you're going to pass out. So and then this head up, putting your head up, is such a simple maneuver with 100% compliance. So I've used that. I haven't used those crossing legs too much because I'm nervous if it doesn't work.
Right. Certainly, a lot of people say that these kinds of patients don't hurt themselves, because they have a warning, and they crump sort of peacefully to the ground and don't hurt themselves, as opposed to epileptics, for example, who go down hard and injure themselves. What do you think about that? Do you think that these people are at risk?
I mean, it's uncommon. I think most don't, but I know of one patient that ended up falling the wrong way, became a quadriplegic, which is for a 16-year-old girl, a pretty bad fall. Many other patients that have knocked their teeth out, whatever. So it's spooky to think about it, but that quadriplegic patient weighs heavily in my mind, where she just, was sitting down, had typical vasopressor syncope. She'd actually donated blood earlier that day and fell the wrong way, and now is a quadriplegic.
Yeah, no, I think people can definitely hurt themselves. I agree. I mean, on average, they don't. And it's not as bad as epilepsy, but some people will hurt themselves.